Hello, my name is Dr. Chris Jenner. I am a consultant in pain medicine and I have my NHS base at Charing Cross Hospital, part of Imperial Healthcare NHS Trust. I've been a consultant in pain medicine for over 12 years now. I also work in the private sector at the London Pain Clinic at 142 to 146 Harley Street. Over the time that I've been a consultant in pain medicine, I have developed a specialist interest in patients who have pelvic pain and also in vulvodynia. I work as part of a multidisciplinary team which includes gynecologists, vulvologists, genitourinary medicine physicians, physiotherapists and psychologists in order to treat patients with a holistic and multidisciplinary approach. So for patients who have pelvic pain and vulvodynia, one of the simplest places to start to treat them is to use analgesic medication. Often we use a combination of anti-nerve pain or anti-neuropathic medication along with other medications such as anti-inflammatories, weak and strong opioid medication. The aim of medication for patients with pelvic pain and vulvodynia is to try and break the cycle of the pain and to reduce the intensity of their pain as much as possible. Why do we do this? Because ultimately we want to break the cycle of the pain so the patient can physically and psychologically rehabilitate. Often the barrier to that rehabilitation is simply the intensity of the pain, which can often be overwhelming. We use a variety of medications, as I mentioned, and these are used either on their own or in combination with one another. And what we're always trying to achieve is to get maximum pain relief for the patient with minimal adverse effects. Once that's been achieved, we would keep the patient on the medication for approximately 6 months, and they would take that medication every day for the 6 months. After the 6 months, we would slowly bring down the dose of the medication with a view to discontinuing it if possible. As we mentioned before, the main reason for this is to break the cycle of pain and to allow the patient to rehabilitate. If the patient fails with medication for whatever reason, and that may be that the medication is not effective or they get significant adverse effects that they can't tolerate, then we may use things such as minimally invasive pain management procedures. Now, for patients with vulvodynia, one very simple and very straightforward procedure is called pulsed radiofrequency to the pudendal nerve. Where patients have more widespread pelvic pain, we do a similar procedure, but we use pulsed radiofrequency, but we use this to the superior and inferior hypogastric plexus and the ganglion of impar. The use of radiofrequency has been used since the 1950s, but certainly in the last decade or so it's really taken off as an effective type of treatment for patients who have nerve pain. And essentially the radiofrequency or pulsed radiofrequency is a non-destructive technique in which the nerves which supply the vulva, vagina and pelvic region, the intensity of any stimulus going through them is reduced and the hypersensitivity is reduced using pulsed radiofrequency technology. In some cases where perhaps this has failed, we will also use Botox injections either into the muscles and into the skin to reduce particularly hypersensitivity of those areas. And overall, as I said, with a combination of medication and or minimally invasive pain management procedures, it should be possible to break the cycle of the patient's pain in order for them to participate fully in physical and psychological rehabilitation treatment.